Hello, everyone. Welcome to Class 6 of Pharmaceutical Policy. Sorry I wasn't able to meet with you on Tuesday, but I hope this YouTube lecture will be useful for you. This is not going to be a 2 hour lecture because that would be a long time to sit down and look at a YouTube lecture and it takes forever to upload. So, what I'm going to do is just sort of rapidly go through the information. And if you have any questions, you can always ask me. Of course, if we were in class, you would be asking plenty of questions, so the class would take longer than if I'm just talking directly to you and going through the information. Talking about Medicare Part D and private plans this week. And the first question I have for the class is, what kind of prescription drug benefit plan would you create? I should say create, not create it, for Medicare beneficiaries. So there are a number of factors you could consider when creating one of these, or maybe a number of these different types of plans. And so, one question is whether or not you should have one plan or multiple plans. Should choice be involved? Should the private sector be involved to help create different choices, different types of benefit plans that you can offer? As you remember, the VA essentially has one plan. They have a national formulary, and they have a little bit of variation at the regional level, but very little. They really try to make sure that all their hospitals are actually using the exact same plan. So if that works so well for the VA, why not do the same for Medicare? Well, Medicare, of course, is a different beast. It's not, as we talked about with the VA, one system. There are all kinds of providers out there that are receiving Medicare dollars. And beneficiaries, of course, are going to all different types of providers, clinics, hospitals, and so on. So it's not easy to administer the benefits in a way that it is for the VA to administer their benefits and to control what's part of their benefits. Also, the Medicare population is much more diverse than the VA population. So, when you think about the needs of the patient population, they're going to be much more varied and much more nuanced than the VA. And you're going to have people who are younger and fit who might not need that many prescription drugs, and then you're going to have other people who need 14 different drugs. So, so having one formulary might actually be a problem because it may not cater to all the different types of populations. Also, this is going to be voluntary. For the VA, if you get VA benefits, you're going to get what they offer you. For Medicare, for Medicare Part D, the individual has to pay a premium unless they're really low income. Then they receive some subsidies. But because an individual has to pay a premium, then they are likely to want to see some different options. So that's one reason we probably wouldn't have just one type of plan. So if we were in class, you guys would give me lots of things. I'm sure something else you might mention is the cost. So you think about the cost to the beneficiary, and you want to keep the cost down as much as possible because you want to save money for the federal government, which means saving us money, saving the taxpayers money. We may want to make sure that the benefit dealt with the varying incomes of beneficiaries. So, for our poor beneficiaries, we definitely need to do something to help them out. So, those are just some factors to consider. You might think about what kind of drugs you offer. This is clearly, an older population, so we're going to need to have all the drugs for chronic diseases available and so on. And you might want to think about ways to keep costs down. If Medicare, especially, is going to run the plan itself, it may want to come up with different mechanisms like prior authorization, finding the best therapeutic equivalent that is also the most costly. The cheapest is what I meant to say. Medicare might do things like that, therapeutic substitution. So they might find different ways to keep the costs down, and in order to make sure the government's not paying too much. All right. So here are just some of the factors. Cost to the beneficiary. Bennies is kind of how people in CMS refer to beneficiaries. So varying incomes of the bennies, the beneficiaries, the people receiving Medicare, drugs included in the plans. We would definitely be concerned about that. What types of drugs are in the plan, and the cost of taxpayers, and whether there's a role of the private sector, role for the private sector here or not is important, and how much choice do we really need? Choice can be really beneficiary, but choice can also be inhibiting, and it can also slow down decision making. Because just imagine when you go to buy toothpaste, where you have now 30, 40 or more different options to buy toothpaste, and somehow you're supposed to pick out the best one, and there's all these different things and ingredients and so on. So just take that decision and multiply it by 100 when you're trying to pick out a prescription drug plan. So we want choice, but we don't want people to have to choose from 200 different plans. That would just be overwhelming. All right. All right, good. So now I want to talk to you some about choice. As you can see, there are a number of different states that offer different numbers of plans. Most of the states have at least 28 prescription drug plans, and then states also offer Medicare Advantage prescription drug plans. So there are two major types of plans. There's Part D standalone plans, and then there are the Medicare Advantage plan. This diagram is just for the standalone plans, as you can see. Um, Medicare requires a defined benefit plan to be offered by any of the prescription drug plan providers. Well, I shouldn't say provider, I should say perhaps offerers or companies, prescription drug plan companies. So there are a number of different companies that offer these prescription drug plans, and they overlap with the PBM. So you can imagine that if you run a PBM, you can definitely run a prescription drug plan for Medicare. And so some of those companies are the same. So Medicare requires, or CMS or Medicare, however you want to phrase it, requires those companies to offer a defined standard benefit or an alternative plan that's similar to that defined benefit. So they're required to offer this defined benefit plan. And what's in that defined benefit plan? Well, it includes a deductible and then 25% cost sharing. And I'm going to show you in a few minutes here how the costs are broken down for the enrollee and for the plan and also for Medicare. And your reading went through that fairly well too. So beyond this defined standard benefit that they offer, they can also offer an enhanced benefit plan. Now they may just only offer the defined benefit. So there may be some plans out there that say, well, we think the defined benefit works for us, and we think we'll get plenty of customers that way. Then we're going to only offer that. There are other plans to say, well, that doesn't make sense because, for one, if we offer just this 25% flat cost share rate, then that means that beneficiaries are going to be paying the same cost share for every drug. Well, that doesn't make sense, right? Given what we talked about, drugs are going to vary in price. Most PBMs, most pharmacy benefit managers, want to incentivize people to use generic drugs, right? So why would you have the cost sharing be the same for all drugs? So what the prescription drug plans tend to do is make the generics cheaper or free, and then they increase the amount of cost share depending on whether a drug is preferred or non-preferred. So that's more of the private sector way of thinking about this. So although Medicare requires this defined benefit plan, they can manipulate that plan a bit to offer something that's very, very similar. So it just has to be actuarially equivalent, which means in insurance speak, essentially it's going to offer people the same value, equivalent value, as when you compare the two plans. Okay. Now, how much choice is there really? It looks like a lot of choice when you look at all these numbers. And there actually used to be even more plans per state. There used to be 40, 50 plans in certain states. And so there seemed to be a lot of choice because the senior has to choose from 30 different prescription drug plans. But there are actually only 10 companies that manage 75% of the market. So this is another area where we see bigger players forming, taking on more and more of the market, and we may see less players as we move forward, and so on. Especially as the ACA adjusts the Medicare Part D prescription drug plans, and makes changes to it and decreases the amount of money that the beneficiary has to pay, then we may see some companies not seeing a business model in this space, and so they may leave, and we may be left with even less players, so that consumers really won't have that many choices available. All right, now you can look at this diagram and try to figure out, well, which state has the most choices or most plans at least, and that's going to be West Virginia and Pennsylvania. So for some reason, I'm not sure why, but just it just sort of gives you a look of what's going on with these different plans. Hawaii seems to have the least, I think, at 28 plans. So there's some variation there in terms of what these plans are going to offer. And then, in addition to these prescription drug standalone plans, they are going to offer a few Medicare Advantage plans too. All right, now prescription drug plans have declined, as I said before, mainly because of all of the merging and consolidating that's going on in the industry, and because of policy change that has changed. So, so let's look at what do people actually select. What type of plan do they usually get? And you can see that most people pick a prescription drug plan, the standalone plan, and then we've got about 21% of the people that select the Medicare Advantage plan. And then there are other people who have other types of drug coverage that are, these are elderly people who would be eligible for the prescription drug plan, but remember it's voluntary, so you don't have to purchase Part D. Part D requires a premium, so we're not going to force anyone to buy Part D, at least not right now, and pay this premium. They can decide whether it's appropriate for them or not. And most beneficiaries are going to take it on. You see the number here is about this is sorry, 46 million. Gives you some sense of the number of people out there who are available, and that's about the same number as of people who have Medicare generally. And then we got some people here who have no coverage. So we still have seniors out there who have no drug coverage at all, which means that they're going to be paying really high rates for their drugs, or perhaps they're very healthy and they just don't need any drugs, and so they see no reason to buy the drug coverage, and they might purchase it at a later date. The top 10 drugs right here, and Lipitor is number one, a cardiovascular drug. People are clearly going to take those drugs, but they're not listed here, and perhaps it's because Medicare knows that plans are likely to offer those common drugs, and they really want them to compete by deciding which of those drugs they're going to offer and not offer. So the restrictions that Medicare puts on coverage is that, well, you have to cover these types of drugs, and you find the typical drugs that are in these categories, and you're okay. You don't have to have all of the drugs in this category. You can have substantially all, right? Okay, let's talk a little bit about money. So, out-of-pocket costs. That's the main thing we're concerned about here is how much is the beneficiary paying. But we also want to give some concern and some thought to how much is government paying, because that means that's how much we as the taxpayers are paying for Medicare Part D. Okay, so in 2011, this is how the out-of-pocket costs look, and this is how the benefit was structured. So when you start off, you pay $310 in a deductible, right? So if your drugs are only $200 for the year, you probably should not get a prescription drug Part D plan. And why is that? Well, that's because you're not ever going to actually benefit from the plan, right? So you're going to pay premiums, and then you're only going to pay $200, $250 for the year in drugs, and you won't even get through your deductible, right? So understand that. Now, you can't predict what's going to happen in life, and you may get really sick, and you wouldn't have known you were going to get really sick, and whatever illness you have might require many more drugs, and so the plan might benefit you because of that unforeseen illness. But if you've been generally healthy for a long time, it may be favorable for you to simply say, "Well, I'm not going to get one of these plans." But so you start there. You have to get through the deductible before you get to the initial coverage limit, and in order to get to the initial coverage limit, you're going to have to pay 25% cost share, and then the plan will pay for 75% of the cost of your drugs. And you have to go all the way up to $2,840. Now, that sounds like a lot of money to spend on drugs in a year because most of you are young, but a number of older people can go through that fairly quickly. And if you are taking a lot of different drugs, you can go through that perhaps in a couple of weeks. So it really just depends on how sick someone is, and that will dictate what they're going to get out of this plan, because it dictates how many prescription drugs they're going to be using. Okay, so now, as a result of the Affordable Care Act, what used to be called the donut hole is no longer here. So this is the donut hole where we have a coverage gap. Typically, this would have been open and it would have been 100% beneficiary paying, or this would have said enrollee pays 100%. But now it says enrollee pays 50% and the manufacturer provides a 50% discount, right? So why is the manufacturer doing that? Because that is a better deal than allowing Medicare to negotiate with them to lower the price of their drugs. So it's better than the alternative that the government was pushing as an option in the Affordable Care Act. So this discount, even though it's substantial, it may not be as big as we might think because we still don't know how much the manufacturer is saying their price should be, and we don't really know where their price is coming from, as we talked about in prior classes. The average manufacturer price is not telling us what it costs the manufacturer to create the drug. It's telling us how much they want to sell it to us for. So when they discount their price, then we're not sure if we're really getting a good deal or not. Okay, so and enrollees only have to pay a percentage of generics, and that will continue to decline. The amount they're paying on brand name drugs is going to go down to 25% by 2020. And so then after you get past this coverage gap, which basically is a drop in your coverage compared to your initial coverage limit, you're going to reach what's called a catastrophic. Oh, sorry, I swear. You're going to reach what's called a catastrophic limit, and that's now that in 2011 that was at 6,448, and after that point, the enrollee would pay 5% of the cost, so they would cost share for 5%, and then the plan would pay 15%, and the Medicare would pay 80%. So you might ask or might wonder, what are the incentives here for the different parties? The incentive for Medicare, obviously, is to keep you down in the I'm not sure what's going on. Might to keep you down in the deductible rate, right? So they don't ever have to worry about paying. But even if they don't do that, then you can go ahead and go through the initial coverage limit, coverage gap, and they definitely don't want you to get to the catastrophic coverage limit. The incentive for the plan is definitely to keep you down at the deductible range, so you continue giving them money, but you're never using the benefits that they are offering. And same for the coverage gap. The plan pays some money too, but the general incentive has been for you to stay out of the coverage gap, or you meaning the beneficiary to stay out of the coverage gap, so that they don't actually have to pay this higher amount of cost share. It's a disincentive to have them enter this range where they are now paying much more in cost share than they were when they started off in the initial coverage limit. All right, so that's just some general idea of how this benefit is structured and what the out-of-pocket costs are. That is the coverage gap right there. Here's a website you can take a look at to show you how the costs are varying for each year. The costs in general are going up. They're going up with inflation. So the $310 deductible is now higher and just continues to get higher. What we're going to see is a drop in overall costs for the beneficiaries and for the federal government and for beneficiaries. Sorry. Well, we can look at this because beneficiaries are going to be paying less money over time because this donut hole is closing, and their discounts in the donuts hole are just going to continue to increase. They're going to eventually get a 25% discount on brand name drugs and even a similar discount on generic drugs. So here we can see that in 2013, catastrophic coverage begins at around 4,750, which is a great discount. And as you see, the discount came mainly from the donut hole decrease in payments that people have to make. So they went from 100% to paying, 48% for brand names and about 79% for of what they pay for generics. So this, the ACA in this case is going to really have some tremendous benefits for Medicare beneficiaries. Okay, so one thing is missing from this chart is premiums. So how much people spend on premiums? Well, in '06 they were spending a lot less than they did in 2011. So premiums are going up about 48%. They're going up here just like they're going up throughout the healthcare industry. Remember, the private plans are running these prescription drug plans. for Part D. So, or the Medicare Advantage plans, they're also running those. So their prices are likely to increase over time, just as they do for any private, sorry, any other aspect of healthcare or any other premiums. All right. So the lowest premium right now, the lowest premium PDP is the Walmart plan that you guys read about. So Walmart getting in this industry has really started to lower the costs that people have to pay um, to have one of these prescription drug plans. And people seem to really like the Walmart plan. About 600,000 people have enrolled in the plan so far. All right. Now, is the premium lower for Medicare Advantage or Part prescription drug plan? Sorry, is the premium lower for a Medicare Advantage plan or just a regular standalone prescription drug plan? The premium is lowest for the Medicare Advantage plan, and that's because the Medicare Advantage plan does more than offer drugs. This is your typical your typical managed care organization that offers clinics, access to hospitals, and all kinds of providers. So their prescription drug plan is just one piece of a really big puzzle in terms of the amount of money they're uh, receiving to provide care to people. So what they do is they lower premiums to attract people to their plan, and they make up their costs in other ways on other types of cost share, on other types of ways that people are actually providing them with money beyond them actually participating in this prescription drug plan. So in that way, they're able to keep the costs down much more. But still, the prescription drug plans, the standalone plans, have more market share, mainly because people don't want to enroll in the Medicare Advantage because they probably like the doctor they already have who uses the fee-for-service version of Medicare. Okay, so here's just an example of who is participating in the low-income subsidy, and it's also less eligibility. So, dual eligibles who are basically poor people who are on Medicare are automatically being enrolled in the subsidy program. So that's really the biggest group and the main group we care most about. And there are some other smaller groups like SSI recipients, Social Security, disability recipients who are getting a lot of these drugs. Then there are people who apply for uh, the subsidy, and then they're going to receive it. And what's different between them and the dual eligibles is that they are not eligible for Medicaid, but they are people with low incomes, and so they're not automatically enrolled. They have to actually pick a particular plan. And then there are people who seem to be eligible for, so that they actually are low income. They seem to be eligible for low income subsidies, but they actually seem to have some other type of drug coverage, and they're not using one that's required by the sorry, not one that's required by or contracted through Medicare. Sorry. All right. So how do these plans keep their costs down? Well, they do the same thing that PBMs do. These prescription drug plans are essentially like PBMs. They put together a formulary. They tier the formulary, and they come up with all kinds of mechanisms to keep people from being able to access drugs that cost a lot of money, and they come up with various mechanisms to keep people to buy drugs that are cheap and likely to have some significant outcome on the individuals. All right, so tiered formularies is one way that this is done. Utilization management, there's prior authorization. We talked about that before. Then step therapy. Step therapy is when you is when a person has to use a particular drug before they get to a more costly drug. So usually the way this is structured is that someone will have to use a generic drug, and then if the generic works, then they stick with the generic. If the generic doesn't work, then they got to move on to a higher level drug, now preferred brand name drug, for example. If that doesn't work, then the prescription drug plan will let them try some other higher level, for example, a new brand name drug that costs more. So what they're trying to do again is to keep costs down. That's what all this is about, and they are recommending that people go stepwise through treatments, but start off with the cheapest ones. They don't want people to start off with the expensive treatment and then it actually doesn't end up working. So that's really important that they don't start with that really expensive one. They want to try to keep the cost down early on. And then also quantity limits, so limiting amount of drug people can have. The pharmacist in another class talked about older men coming into the pharmacy complaining that they can only get a limited amount of Viagra. So the quantities have pros and cons. They can actually cramp some people's lifestyle. But of course, if you want more of that Viagra and your prescription drug plan limits the amount you can get, then you have to go pay out of pocket if it is that meaningful to you. All right. Now, how do people choose a plan? Here's a link that you can use that I would, if we were in class, I would click on this and show you that there's a company called Q1 Medicare that assembles information on Part D plans, helps people. They've created a calculator that helps people to find the drugs they're taking and to see if a particular plan is actually going to cover that drug and for how much money that plan would actually cover that drug for how much premium would a person actually have to pay. So you first look for your drugs, then you look at the costs of the plan because that's cost sharing that's required for a coverage gap. All right, so that's it for the Medicare Prescription Part D plan. Again, ask me any questions you have. Sorry, I know I'm a bit sick here and it may not be easy to hear everything I'm saying. So if there's some question that you have, just send me a question and I'll respond appropriately to it. Okay, so the private insurance plans are pretty much boiled down to PBMs. So we've talked about PBMs before. You have some good reading on PBMs, so the pros and cons of PBMs and how they function and so on. You had a reading by GAO on the effectiveness of PBMs in terms of keeping the price down for the federal government. So they seem to actually work. They do their job, but remember, all PBMs do is cut deals. So they try to make a deal that's going to end up with you having lower prescription drug prices. That's the ultimate goal. Remember, as we talked about before, we have buyers and sellers in this market. The buyers are always trying to keep the price down. That would be you as the beneficiary and the insurance company when it pays for your prescription drugs. It wants to keep the price down as low as possible. And then we have people who are sellers, and they're of course trying to sell for as much as possible. So just keep that in mind, even in this context too. So PBM dominated. An example is GWU. George Washington University is the second largest employer in DC, but we only have one option for our PBM. And what do we use? We use CVS Caremark. So CVS is around the corner from GW. It's easy for anybody here to go access them. They're around the corner from just about everything else in this area. So there are CVS's all over the place. And so you can easily access your drugs if you have this CVS plan. So it makes sense to have this in the DC metro area. The CVS Caremark plan that we're being offered is not so different from any other plan that you might see out there for buying prescription drugs. The mail order is cheaper. And that makes sense because you get rid of the bricks and mortar, which means you get rid of the building, you get rid of the people that are involved, and so on. And you can basically keep your costs down by sending something to people by mail instead of having them come in and interact with an individual in a retail store that you have to keep open. In some cases, it might be open for 12, 16 hours in a day in order to provide drugs throughout the day to all the customers who want the drugs. All right. And there's also a retail option for you, but you're really being incentivized to use mail order. Of course, Mail order really is only good for certain types of people, and it's mail order works best for people with chronic illnesses, not people who are really healthy and they kind of fluctuate in terms of what drugs they might need. Mail order is best because you can get a 90-day supply and you can keep it for a long time. And as one person mentioned in another class, you could travel better when you have that 90-day supply too, because you might go off somewhere where you like access to medications. But GW is nice in that it also offers this additional 30-day supply for one time per year. If you look at the bottom of this diagram, you see vacation exception, and that vacation exception is essentially helping people who are going to be in a circumstance where they're traveling for a long time and they don't have their drugs and they're going to actually need their drugs. So, GW also offers a maintenance plan where essentially GW is saying, well, if you order 90 days of a particular prescription, you can get through mail order, but you can also get it at your local CVS. So they're actually offering people the same price for drugs at the CVS, at the retail side, and for mail order. And this is different from what I just showed you because this is focused on people getting a 90-day prescription from the retailer. Now, if you go to a different retailer, then you're going to have to pay much more money. So this is basically keeping you at the CVS pharmacy. And if you go to some other retail place other than CVS, then you see the prices are substantially more than if you actually would just stay with the CVS. So you're being incentivized to stay with them, but they're not saying, that. Well, sorry, they are really just trying to incentivize you to stick with them. Now, what do they get out of this? Well, supposedly, according to CVS, they actually save money, or sorry, beneficiaries actually save money when they are using the mail order approach because they are able to comply with the medications. More medications are available for them, and this is great for chronic conditions. And so CVS is saying they really care about medication adherence. Of course, this also means that people are coming back to them on a regular basis, and that's how they make plenty of money off of individuals in that way. All right. So here's the here in at this point, I would have discussed the GAO report with you some that you had to read. And the big question here is, do PBMs work? And they seem to work. They seem to save the government quite a bit of money. And they've cut the cost for the federal government. They do the same with all health plans. So someone asked me recently, I was just giving a brief talk on pharmaceutical policy, and someone asked me, well, why are these PBMs even in this market? And why would an insurer allow them? Well, it just turns out they have figured out ways to get deeper discounts than the insurer could get. The insurer was typically paying the pharmacist. They weren't going through the drug manufacturers to get discounts on drugs, but the PBM is doing that. They're getting a deal from the manufacturer, and they're lowballing the pharmacist so they can get a deal from the pharmacist too. And so they are able to keep the cost down and at the same time get some money out of this equation for themselves. And of course, some of these PBMs own mail order pharmacies. So the trick there is that they decide what you take, and then they also dispense what you're taking. So they have a lot of control over what you are going to be taking, how much you're going to be paying for it. So some people argue that they have a conflict of interest in this area for that reason when you have a PBM with that much power. So impact on the taxpayers, well, it's good to use PBMs on the government side because they actually help us out quite a bit and they save us some money, so we like those. Now, what's the challenge? The challenge is that they have a lot of power, right? So these PBMs are getting money from a variety of different sources. Here you can see, if you look at the gray arrows, that's the money coming to them. So they're getting administrative fees from health plans, and those are always questionable. Administrative fees for anyone can always be difficult to calculate, and so you can imagine that if they need a little more money, they might say their administrative fees have gone up for whatever reason, in order to get a little more money in their coffers. Um, then the health plans are paying them for the drugs that are being provided to the beneficiaries. So in the case of Medicare is giving the prescription drug plans some money, and they're out there trying to save money for Medicare by negotiating with manufacturers and negotiating with pharmacists to keep the costs down. Pharmaceutical manufacturer will be paying the PBM rebates and it says other amounts of money, but basically they're paying the money mainly to get on their formulary and to get certain placement on their formulary. Then we're paying them, we being the enrollee this time. So the enrollee is paying for their mail order drug from the PBM for a PBM that has a mail order service. The enrollee is also paying for a cost share uh, when they go to, well, either from the PBM or they're paying a cost share when they're going to the retail drug store. I'm sorry, I phrased that incorrectly. So they're paying a mail order drug cost share. So when they get their mail order drug from a PBM, they're going to send some cost share to that PBM if that PBM runs a mail order pharmacy. Otherwise, they're paying it to some other mail order pharmacy. And then if they go into a store, a retailer, then they're going to pay cost share to them. Of course, when you got CVS Caremark around, CVS also owns the retailer. So the beneficiary is actually just giving them all their cost share too. So you can see how this just seems a little strange that one industry player has so much power that it's offering the mail order pharmacy and the non mail order pharmacy, uh, and they're actually getting money from the enrollee from both, and the enrollee is also paying a premium to the health plan, which then is cycling back to the beneficiary, and that just seems like that's a lot of sort of control in the hands of one company. So the big issue here is have, right? So your case study was all about power, and the question I leave you with is: are these PBMs too large? Now we have Medco and Express Scripts who dominate most of the market, and they have about 40% of the market. Sorry. And then after that, you've got CVS Caremark, and those are the big players out there. And the question is, do they really have too much power? Are they sort of taking over? Are they controlling the pricing too much? Are they reducing the bargaining power, the leverage that pharmacists have? Of course, in a market where PBMs are so large, it's hard for any small retail pharmacy to really cut a good deal with them. They're probably always going to lowball the independent pharmacies or pharmacists that are out there, and they're going to offer the better deal to the place that can offer um, um, much more access to customers, and that's larger, and so it has more bargaining power, and it can actually keep the price relatively decent and I guess appropriate for what the pharmacy actually needs. All right, now Costco is also getting in this business too. So Costco has actually formed a PBM, and their PBM is focused on mid-sized and small businesses. And what they're trying to do there is is that they are trying to get those businesses employees to become members of Costco. And so when they come into Costco for the drugs, of course, they're going to have to get a membership card to come in for drugs. Then they'll get a deal on their drugs. And then what else will they do? Well, they're going to buy other stuff. They're going to buy giant bags of Cheetos and Doritos and 50 cans of green beans and whatever else you buy at Costco. So Costco's going to make more money off of this because they're going to potentially get more customers. It will probably be a good deal for these small and mid-sized businesses who are offering some level of a health benefit to their workers, and they want to add on this prescription drug plan for their workers, and they say we're going to do it through the PBM at Costco because they can set up a better pricing structure than I can as a business, and hey, Costco is out there offering it. It's looking good. Prices are looking pretty good. They're going to try it out. And so we'll see how that affects the market. Clearly, Walmart has an impact and continues to have an impact. But Costco may have a much more of an impact than some people think, too. We'll see. It sort of remains to be seen. All right, well, that's it for this time. Sorry about any confusion that may have been caused here as I'm getting through this material based on the sound of my voice or any other issues here. So just let me know if there's any questions. This is much shorter, as I said, than a regular lecture. Sorry, because um, the you guys aren't asking any questions, and I'm not able to walk you through the material. So ask any questions you have. I'm sorry I wasn't able to give the lecture to you in person, but I'll respond to any questions you have, and I'll see you next week.